Good morning, student. Today's lecture is on the thyroid gland. Competencies for the thyroid gland are describe and demonstrate location, parts, borders, surfaces, relations, and blood supply of the thyroid gland. Describe the anatomically relevant clinical features of thyroid swelling. Objectives for the today's lecture are describe the external features, location, lobes, coverings, and surgical anatomy. Describe the blood supply and nerve supply of the thyroid gland. Describe the anatomical basis of applied anatomy. So these are the objectives of today's lecture for the thyroid gland. Thyroid gland is the largest endocrine gland located anteriorly in the lower part of the neck. Here you can see the thyroid gland, which is located in the neck. Special features for the thyroid gland. It is the only endocrine gland which is located superficially in the body. Hence, it is accessible for physical examination. Thyroid gland depends on external environment for raw material to synthesize its hormones. Thyroid gland manufactures hormones, store them, and release for use as per requirement. It has richest blood supply. Location. Thyroid gland is located in the lower part of the front and side of the trachea, opposite the 5th, 6th, and 7th cervical vertebrae and the 1st thoracic vertebrae. So here you can nicely appreciate the location of the thyroid gland, which is situated in the lower part of the front and side of the trachea. Here is the trachea. So it is located on the front and side of the trachea, and the vertebral level is from 5th cervical vertebra to the 1st thoracic vertebra. Extent of the thyroid gland. It extends from the oblique line of the thyroid cartilage to the 5th or the 6th tracheal rings. So here you can see the oblique line of the thyroid cartilage, and here is the line drawn for the 5th and the 6th tracheal cartilage ring. So this is the extent of the thyroid gland from the oblique line of the thyroid cartilage to the 5th to 6th tracheal cartilage ring. Vertebral level is from the level of the 5th cervical vertebra to the 1st thoracic vertebra. Coverings or the capsule of the thyroid gland. Thyroid gland is invested by two layers, inner true capsule and the outer false capsule. So here is the true capsule. Here is the true capsule and here is the false capsule. So here is the true capsule and the false capsule. True capsule is formed by the peripheral condensation of the fibrous stroma of the gland. And the false capsule is derived from the splitting of the pretracheal fascia. In the last lecture of the deep cervical fascia, we have seen that pretracheal fascia invades the thyroid gland. Important features of the false capsule. It is thin along the posterior border of the lateral lobe. So the false capsule is thin along the posterior border of the lateral lobe of the thyroid gland. It is thick on the medial surface of the lateral lobe. It is thickened to form ligament of Berry, which connects the medial surface of the thyroid gland with the cricoid cartilage. Pretracheal fascia, after enclosing the thyroid gland, is attached to the oblique line of the thyroid cartilage and body of the thyroid bone. Relations between the capsule and the vessel. The dense venous plexus lies deep to the true capsule. Therefore, during the thyroidectomy, the gland is removed along with the true capsule to avoid the hemorrhage. So, this is the relation between the capsule and the venous and the vessels. Why thyroid move up and down during the swelling? Because its capsule is attached to the laryngeal cartilages and hyoid bone, which moves up and down during the swallowing. Thus, thyroid swelling can be distinguished from the other swelling in the neck region. So, the thyroid gland moves during the swallowing up and down because its capsule is attached to the laryngeal cartilages and the hyoid bone, and which moves up and down during the swallowing. Thus, and therefore the thyroid swelling can, and this is the one of the most important point to distinguish between the other swelling from the thyroid swelling. Shape of the thyroid gland. Thyroid gland is H-shaped and it consists of two lobes, right and the left, which are joined by the isthmus. So here you can see the right and the left lobe, and in the mid connecting lobe is isthmus. Sometimes a small pyramidal lobe projects upward from the isthmus, usually to the left of the midline. So in this way, you can see sometimes a small pyramidal lobe projects upward from the isthmus, especially from the left to the from the left of the midline of the isthmus. Pyramidal lobe can be connected to the body of the hyoid bone by the fibromuscular band that is known as the levator glanduli thyroid. So here you can see the pyramidal lobe which is connected to the hyoid bone by the levator glanduli thyroid. Also here you can see the levator glanduli thyroid. So here is the hyoid bone and here is the pyramidal lobe which is connected by the levator glanduli thyroid. Here also you can see the levator glanduli thyroid and here is the pyramidal lobe. It is a cadaveric picture. Thyroid gland has anterior view and these two figures show the anterior and the posterior views of the thyroid gland. Weight and dimensions. Each lobe measures 5 centimeter in length, 2.5 centimeter in the width and 2.5 centimeter in the thickness. Isthmus measures about 1.2 centimeter vertically and 1.2 centimeter transversely. Weight is about 25 grams. It is larger in the females than the males. It increases in size during the pregnancy and the menstruation. So each lobe of the thyroid gland is 5 centimeter in length, 2.5 centimeter in width, and the thickness is also 2.5 centimeter. Isthmus measures about 1.2 centimeter vertically and transverse. Weight is about 25 grams. It is larger in the females than the males, and it increases in size during the pregnancy and the menstruation. Presenting parts of the thyroid gland. Each lateral lobe is pyramidal in shape and it has apex, base, three surfaces, anterolateral surface, medial surface, and the posterolateral surface, and the two borders, anterior and the posterior borders. Okay. Apex. Apex of the thyroid gland is directed upwards and slightly lateral. It extends up to the oblique line of the thyroid cartilage. Apex is sandwiched between the inferior constrictor muscle and the sternothyroid lateral. So the apex is directed upward and slightly laterally. Here you can see the apex. And it extends up to the oblique line of the thyroid cartilage. Apex is sandwiched between the inferior constrictor muscle and the sternothyroid muscle laterally. Superior thyroid artery and external laryngeal nerve diverge from each other close to the upper pole. Therefore, the ligature of the superior thyroid artery is applied close to the gland. So, near the apex, the superior thyroid artery and the external laryngeal nerve diverge from each other, and therefore, the ligature for the superior thyroid artery is applied close to the gland. So here you can see superior thyroid artery and the external laryngeal nerve, and they diverge from each other near the apex of the thyroid gland. Here also you can see. Base extends up to the fifth to sixth tracheal rings. It is related to the loop of the inferior thyroid artery and the recurrent laryngeal nerve. Sometimes recurrent laryngeal nerve passes in front or behind the loop of the inferior thyroid artery or between the division of the artery. So therefore, a ligature of the inferior thyroid artery should be applied away from the gland to avoid the injury. So the base is extend up to the fifth or the sixth tracheal ring. It is related to the loop of the inferior thyroid artery and the recurrent laryngeal nerve. Sometimes this recurrent laryngeal nerve passes in front or behind the loop of the inferior thyroid artery or between the divisions of the artery. Therefore, a ligature of the inferior thyroid artery should be applied away from the gland to avoid the injury. Anterolateral or the superficial surface. It is overlapped by the sternothyroid and the sternohyoid muscles along with the superior belly of the omohyoid and the part of the sternocleidomastoid muscle. So, anterolateral surface or the superior surface of the thyroid gland is overlapped by the sternothyroid, sternohyoid, superior belly of the omohyoid and part of the sternocleidomastoid. So, here are the relations of the lateral surface. Here is the sternocleidomastoid, sternohyoid, sternothyroid, and the omohyoid, 4 muscles. Medial surface is related to the two tubes, trachea and the esophagus. Here you can see. Nerve extend the external laryngeal nerve and the recurrent laryngeal nerve. So here is the recurrent laryngeal nerve, which lies between the groove, between the esophagus and the trachea. So the medial surface is related to the trachea and the esophagus, two nerves, external laryngeal nerve and the recurrent laryngeal nerve, and two muscles, inferior constrictor muscle and the cricothyroid muscle. Posterolateral surface is related to the carotid sheath and its content. So here you can see the carotid sheath, which is related to the posterolateral surface of the thyroid gland. And this carotid sheath contains the common carotid artery, internal jugular vein, and the vagus nerve. So these are the three structures which are present in the carotid sheath. Borders. Anterior border separates the superficial surface from the medial surface. This border is accompanied by the anterior descending branch of the superior thyroid artery. Posterior border separates the medial surface from the posterolateral surface and related to the following structure. A longitudinal anastomosis between the superior thyroid artery and the inferior thyroid artery. Parathyroid glands. Lower part of the border is related to the thoracic duct on the left side. So thyroid gland has anterior border and the posterior border. Anterior border is accompanied by the anterior descending branch of the superior thyroid artery. Posterior border is related to the longitudinal anastomosis between the superior thyroid artery and the inferior thyroid artery and the parathyroid glands. So here you can see on the posterior surface, there is an anastomosis between the superior and the inferior thyroid arteries, and these are the parathyroid glands, superior and the inferior parathyroid glands. Okay. Relations of the isthmus. Isthmus connects both the lobes. Sometimes it is absent. Anteriorly, it is related to the sternothyroid, sternohyoid muscles, investing layer of the deep cervical fascia, anterior jugular vein, superficial fascia, and the skin. Posteriorly, it is related to the second, third, and the fourth tracheal rings. Okay. So, isthmus is related anteriorly to the sternothyroid, sternohyoid muscles, investing layer of the deep cervical fascia, anterior jugular vein, superficial fascia, and the skin. Posteriorly, it is related to the second to fourth tracheal rings. Upper border of the isthmus is related to the arterial anastomosis between the two superior thyroid arteries. Sometimes pyramidal lobe extends upward from the isthmus. Here you can see. Here is the isthmus and this is the pyramidal lobe. Lower border is related to the inferior thyroid veins, arteria thyroidea ima if it is present. Arterial supply of the thyroid gland. Thyroid gland is supplied by the superior thyroid artery, which is the branch of the external carotid artery. It penetrates the superficial surface of the gland. Inferior thyroid artery is the branch of the thyrocervical trunk, and this thyrocervical trunk is the branch from the first part of the subclavian artery, and it penetrates the deep surface of the gland. Arteria thyroidea ima, which is present in 10 to 30% of cases, and when it is present, then it is a branch from the either brachiocephalic trunk or the arch of aorta. It supplies the anterior surface of the isthmus it supplies the anterior surface and the isthmus of the thyroid gland. So sometimes you can see the arteria thyroidea ima, and when it is present, it is a branch from the brachiocephalic trunk or the arch of aorta, and few branches from the esophageal and the tracheal arteries. So our thyroid gland is supplied by the superior thyroid artery, which is the branch of the external carotid artery, inferior thyroid artery, which is the branch from the thyrocervical trunk, and it is the branch of the first part of the subclavian artery. And sometimes you get the arteria thyroidea ima, which is the branch either from the brachiocephalic trunk or the arch of aorta, and few branches from the esophageal and the tracheal arteries. So here you can see the external carotid artery. Here is the superior thyroid artery. Here is the first part of the subclavian artery, thyrocervical trunk, and here is the inferior thyroid artery. Okay. Venous drainage. Veins do not accompany the arteries. They arise from the venous plexus, which lies deep to the true capsule and drained by superior thyroid vein, which runs along the outer border of the superior belly of the omohyoid and drains into the internal jugular vein. Middle thyroid vein drains into the internal jugular vein. A bunch of inferior thyroid veins emerge from the lower border of the isthmus and drain into mostly in the left brachiocephalic vein. Sometimes Kocher's vein may be present, and it emerges from the lower pole and drains into the internal jugular vein. So here is the superior thyroid artery, superior thyroid vein, and here is the internal jugular vein. Here is the middle thyroid vein, and here is the inferior thyroid vein, which directly drains into the left brachiocephalic vein. And here you can see the Kocher's vein, okay, from the lower pole of the thyroid gland. Lymphatic drainage. The lymphatics of the gland drain into the prelaryngeal group of lymph nodes in front of the cricothyroid membrane, pretracheal lymph nodes in front of the trachea. Here you can see the pretracheal lymph nodes. These are the prelaryngeal lymph nodes. Then paratracheal lymph nodes along the side of the trachea. Upper and the lower deep cervical lymph nodes along the internal jugular vein here, and the brachiocephalic lymph nodes. So these are the paratracheal lymph nodes, pretracheal lymph nodes, prelaryngeal lymph nodes, upper deep cervical lymph node, and the lower deep cervical lymph node. So this is the lymphatic drainage of the thyroid gland. Innervation of the thyroid gland. Thyroid gland is supplied by the parasympathetic and the sympathetic nerves. Parasympathetic is derived from the vagus and recurrent laryngeal nerves. It is derived from the superior, middle, and the inferior cervical sympathetic ganglia. Nerve reach the thyroid gland, cardiac periarterial plexus, superior and the inferior thyroid plexus. Only vasomotor fibers causing the constrictions of the blood vessels. Endocrine secretions from the thyroid gland is hormonally regulated by the pituitary gland through the TSH. So, sympathetic innervation of the thyroid gland is derived from the superior, middle, and the inferior cervical sympathetic ganglia. Here you can see these three ganglion of the sympathetic trunk. Okay. Coming to the clinical anatomy, enlargement of the thyroid gland is known as goiter, which may be associated with the hyperfunction or the hypofunction of the thyroid gland. Thyroid swelling moves with the deglutition. We already saw the why it moves with the swallowing or the deglutition. Thyroid carcinoma may spread through the lymph vessels or through the blood. Malignant growth of the thyroid gland invade the neighboring structures and produce the pressure symptoms. So the thyroid carcinoma may be spread through the lymphatic vessels or through the blood vessels. And malignant growth of the thyroid gland invade the neighboring structures and produce the pressure symptoms. Pressure effects of the enlarged thyroid gland vary depending on the structure or the structures compressed are. If the trachea is compressed, the effect of compression may be dyspnea, shortness of breath. If the esophagus is compressed, then there will be dysphagia or difficulty in swallowing. If there is a compression of the recurrent laryngeal nerve, then there is hoarseness of voice. When there is compression of the carotid sheath, it will be posteriorly displaced. If there is compression of the sympathetic chain, then the Horner's syndrome. Both the thyroid arteries are related to the nerves, which must be avoided when trying to ligate these arteries. So, external laryngeal nerve and the recurrent laryngeal nerve care should be taken. Ligation of the thyroid arteries during the thyroidectomy. Superior thyroid artery and the external laryngeal nerve diverge from each other near the apex. Artery lies superficial and the nerve lies deep to the apex. Therefore, during the thyroidectomy, superior thyroid artery should be ligated close to the apex of the thyroid gland. Ligation of the thyroid arteries during the thyroidectomy. Recurrent laryngeal nerve lies close to the inferior thyroid artery near the base of the thyroid gland. So, external laryngeal nerve diverge from each other near the apex. Therefore, during the thyroidectomy, inferior thyroid artery should be ligated away from the base of the thyroid gland. So, here you can see the relations of the superior thyroid artery and the external laryngeal nerve. Here, recurrent laryngeal nerve and the inferior thyroid artery. Injury to the recurrent laryngeal nerve produces hoarseness of voice, difficulty in breathing. Recurrent laryngeal nerve supply all the laryngeal muscles except the cricothyroid. Injury to the external laryngeal nerve produces the monotonous voice because of the paralysis of the cricothyroid muscle. Presence of thyroid edema artery, which will produce profuse bleeding if care is not taken. Thyroglossal duct cyst, remnant of the thyroglossal ducts at any point in the way of descent. It may be midline near the head or it may be in the line of thyroglossal duct. Pyramidal lobe and the presence of levator glanduli thyroid. Ectopic thyroid gland, lingual or the higher, which may be higherly placed. Accessory thyroid glands in the thymus or the thyroid muscle. Non-neoplastic, non-inflammatory enlargement is known as the goiter. Endemic goiter, which occurs because of the deficiency of the iodine in the soil or the water. Subtotal thyroidectomy often prefers hyperthyroidism to preserve the external and the recurrent laryngeal nerve to spare the parathyroid gland to prevent the post-operative myxedema. Injury to the recurrent laryngeal nerve produces the hoarseness of voice, temporary aphonia, or the dysphonation laryngeal spasm. Recurrent laryngeal nerve supply all the laryngeal muscles except the cricothyroid. Injury to the external laryngeal nerve will produce the monotonous voice. So here you can see the thyroglossal cyst, thyroglossal fistula. Developmental anomalies are anomalies in the shape, anomalies of the position, ectopic thyroid glands, remnants of the thyroglossal cyst. So these are the anomalies of the development. So this is the cadaveric picture showing the thyroid gland with the pyramidal lobe, and here is the thyroid glandule is present. Okay. So in this way, during the dissection, you can see the thyroid gland. So this is all about the thyroid gland. You may get full question on the thyroid gland or the short note like blood supply of the thyroid gland, clinical anatomy of the thyroid gland, describe the lobes of the thyroid gland. In this way, you can get the questions on the thyroid gland. So thank you.